All right, listen up. This is it. The Cardiomyopathy Masterclass. Final review. We are locking this knowledge in for the boards right now.
We're going straight into the cardiomyopathy blitz. Integrate the mechanics, master the decision tree, save the life. Let's move.
Dilated? Think balloon. It's systolic failure. In survival, that depends entirely on the 4 pillars of therapy.
The hypertrophic, that's the wall, thickened, diastolic failure. The red flag is always sudden cardiac death.
Restrictive, the heart of stone. Amyloid is king here, and what you're going to see is that classic biatrial enlargement.
ARVC, arrhythmogenic right ventricular cardiomyopathy. It's fat infiltrating the heart. You look for epsilon waves on the EKG, and the number 1 rule, you tell the patient to stop the exercise. Period.
For treatment, you remember the Fantastic Four. You've got your ARNIs, angiotensin receptor neprilysin inhibitors, your beta blockers, your MRAs, mineralocorticoid receptor antagonists, and your SGLT2 inhibitors. Now, if that sudden death risk is high or the ejection fraction is in the tank, you better be thinking ICD.
And now, before we proceed any further, we must pause for a mandatory disclaimer.
This content is for educational purposes for USMLE and international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
Sarah, we have mastered the individual phenotypes, but on the boards, the questions are about the next step in management. If you see a patient with a reduced ejection fraction, say 35%, and a dilated heart, what is our absolute first move?
We must start guideline-directed medical therapy, GDMT, immediately, Dr. Collins. According to the 2022 AHA and 2023 ESC guidelines, we need the 4 pillars: an RNI like sacubitril/valsartan, a beta blocker, an MRA like spironolactone, and an SGLT2 inhibitor. This combination has the highest proven mortality benefit for HFrEF.
Correct. But what if the heart isn't dilated? What if it's the hypertrophic wall? Does our decision tree change for ICD placement?
Significantly, in HCM, we don't wait for the ejection fraction to drop because the EF is often supernormal. We use the 2023 ESC risk calculator. If the patient has a wall thickness of 30 millimeters, family history of sudden death, or unexplained syncope, we recommend an implantable cardioverter defibrillator, ICD, for primary prevention.
Precisely. Everyone, pay attention to the resources and guidelines linked below. The 2023 ESC document has specific flowcharts for amyloidosis management in restrictive cases. If it is transthreaded amyloid, we now have tafamidis.
Sarah, what about the most high-yield step-up in diagnostics for all these patients?
It is always the genetic screening. Since most of these HCM, ARVC, and many DCM cases are autosomal dominant, the 2023 guidelines are very strict about screening first-degree relatives. If you find a mutation in the father, the children need clinical and genetic testing.
Outstanding. Finally, let's talk about the ARVC decision tree. If a young athlete has epsilon waves and a dilated right ventricle, what is the most important non-pharmacological prescription?
Exercise restriction. You must tell them to stop competitive sports immediately to prevent mechanical stress from destroying more desmosomes.
Excellent. Sarah, let's lock in the final decision tree. Time for the chat.
Ready? Dilated needs the 4 meds.
Hypertrophic needs the score. SCD risk.
Restrictive is the stain. Congo red.
ARVC is the abstain, no sports. And finally, EF, low, ICD, go. Remember this, and make sure you review those links below.
Decision tree is locked and loaded, Dr. Collins. 4 pillars, SCD score, and review the links. Got it.
All right, here's our question of the day for all of you out there. You know, in the real world, in your clinical practice, is it tough convincing patients to start 4 different meds all at once for heart failure? Seriously, how do you explain the 4 pillars to them in a way that clicks? Drop your strategies in the comments below. We all want to learn from each other.
You've done it. You have mastered the Cardiomyopathy Masterclass. You are ready to go in there and crush the boards. Make sure you subscribe, because our next series on infective endocarditis is right around the corner. Now go save some hearts.